Aside from Rafferty-Long modification, Hill-Sachs defect can also be demonstrated using the striker notch method. It is an apiaxial projection that was described by Hall, Isaac, and Booth. So for this method, the patient is placed in a supine position with the arm flexed slightly beyond 90 degrees. The palm of his hand is resting on the top of his head as this places the humerus in a slight internal rotation. And the body of the humerus should be parallel with the body's mid-sagittal plane. An angulation of 10 degrees cephalad directed to the coracoid process is desired for the striker notch method to visualize the posterior superior and posterolateral areas of the humeral head. Now let's proceed with the projections that will demonstrate the glenoid cavity. So glenoid cavity is a shallow oval depression at the lateral angle of the scapula where the humeral head articulates. So first we have the EP oblique projection, Grassi method. So the patient could be in an upright or supine position, but having them in an upright position is more comfortable. The patient can be placed in LPO or RPO position depending on the affected side being closest to the image receptor. If the patient is in upright position, rotate their body 35 to 45 degrees towards the affected side. While if in supine position, have them rotated at greater than 45 degrees to place the scapula parallel with the image receptor. The arm should be slightly abducted with the palm of the hand placed on their abdomen. The central ray is directed perpendicular to a point 2-inch medial and 2-inch inferior to superolateral border of the shoulder to demonstrate the glenoid cavity. Another method to visualize a glenoid cavity, specifically used to demonstrate loss of articular cartilage in the scapulohumeral joint, is the Apple method, AP oblique projection. The patient is in upright position with the body rotated 35 to 45 degrees towards the affected side to place the scapula parallel with the image receptor. So with a 1 pound weight on their hands, the patient will abduct their affected arm 90 degrees. The central ray is directed perpendicular at the level of the coracoid process. So the last method for the glenoid cavity is the Garth method. It is an apiaxial oblique projection. So for this method, patient could be in upright, seated, or supine position with the body rotated 45 degrees towards the affected side, and the elbow is flexed to place the arm across the chest. So the central ray is directed 45 degrees caudad to the scapulohumeral joint. So this method is used for acute shoulder trauma for identifying posterior scapulohumeral dislocations, to check for glenoid fractures, Hill-Sachs defect, and as well as soft tissue calcification. So the next projection is for the supraspinatus outlet, or what we also call as coracoacromial arc. It is found as the area above the crest of spine of the scapula, and it gives origin to the spinatus muscle. So first we have here the near method, tangential projection. It is used to demonstrate the coracoacromial arc tangentially and used to diagnose shoulder impingement. So for this projection, the patient could be in a seated or upright position with the unaffected side rotated 45 to 60 degrees away from the image receptor, and the arm is placed at the side of the patient. The central ray is directed 10 to 15 degrees caudad to the superior aspect of the humeral head to demonstrate the posterior surface of the acromion and the acromioclavicular joint. Now let's proceed with a projection that will demonstrate the intertubercular groove, or what we also call as the bicipital groove. It is a deep depression between the lesser and greater tubercle where the biceps tendon pass through. A tangential projection where the patient is in supine position with the IR placed vertically against the shoulder can demonstrate the intertubercular groove. The patient's chin is extended, the head is rotated away from the affected side, and the hand is supinated for this projection. The central ray is directed 10 to 15 degrees posteriorly to the long axis of the humerus, entering the intertubercular groove when the patient is in supine position. And another way to demonstrate the intertubercular groove is the Fisk modification, where the patient is in upright position, elbow flexed so that the posterior surface of the forearm is placed against the table while grasping the horizontal image receptor. Sandbags may be used as a support for the hands. Have the patient lean forward to place the humerus 10 to 15 degrees from the vertical position and direct the central ray perpendicular to the intertubercular groove. So the next projections will demonstrate the acromioclavicular joints. It is between the acromion process of the scapula and the acromial extremity of the clavicle. First is the bilateral AP projection, Pearson method. This will visualize both left and right acromioclavicular joints. So for Pearson method, it is done with 2 exposures while the patient is in upright or seated upright position. Having the patient in recumbent will reduce the ACJ joints. When we say ACJ, it also means as acromioclavicular joint. So the patient will be facing the X-ray source or the X-ray tube with both arms hanging on their sides unsupported. One exposure is performed without weights, and the second exposure is performed with weights of 5 to 10 pounds affixed on each of their wrists. Avoid having the patient hold weights in each hand, as this tends to make the shoulder muscles contract, thus reducing the possibility of demonstrating a small acromioclavicular separation. The central ray is directed perpendicular, entering a point between level of the ACJ. So Pearson method is used to demonstrate dislocation, separation, and function of the acromioclavicular joint. Next projection is used for the demonstration of suspected acromioclavicular subluxation or dislocation. The AP axial projection, Alexander method. So here, the patient is in upright or seated upright position with the coracoid process in center to the image receptor. The central ray is directed 15 degrees cephalad to the coracoid process to project the acromioclavicular joint above acromion. To demonstrate the relationship of the bones of the shoulder, PA axial oblique projection, also called Alexander method, is performed. The patient is in upright position, RAO or LAO, depending on the affected side. The body is rotated to place the MCP 45 to 60 degrees from the image receptor and for the scapula to be perpendicular with the image receptor. The hand of the affected side is placed under the opposite axilla and the arm pulled firmly across the chest to draw the scapula laterally. The central ray is directed 15 degrees caudally to the acromioclavicular joints. So the next projection will demonstrate the clavicle. When examining for AP projection, patient could be in an upright or supine position. Having the patient in supine reduces the possibility of fragment displacement or additional injury. Okay, so while facing the X-ray source or the X-ray tube, have the arms placed along the sides with the affected clavicle centered to the image receptor. The central ray direction is perpendicular to the mid-shaft of the clavicle. This projection will demonstrate a frontal image of the clavicle. If the desired image should have an improved contrast and reduced magnification due to OID, PA projection can be performed. Instead of having the patient facing the X-ray source, their clavicle will be in direct contact with the image receptor while facing it. And this projection is well accepted for patients who can stand. Next is the apiaxial projection of the clavicle in lordotic position. So here the patient is in upright position with one foot in front and leaning backward until the neck and shoulder touches the image receptor. If the patient cannot assume lordotic position, we can place them in supine with a central ray angulation of 15 to 30 degrees cephalad. If the patient is in upright position, direct the central ray 0 to 15 degrees cephalad depending on their lordosis. Both central ray angulations are directed to the midshaft of the clavicle, and this will demonstrate the clavicle above the ribs. Next is the PA-axial projection. It is the same with the AP-axial, but this calls for a prone position with a 15 to 30 degrees caudal angulation directed to the midshaft of the clavicle. This will also project the clavicle above the ribs, but with an improved image contrast and reduced OID. To project the clavicle free of chest wall, an infero-superior image should be obtained with a tangential projection. So the patient is in supine position with arms along the side and depressed shoulder. Have the patient's head turned away from the side of interest to place the IR in contact with the superior surface of the shoulder. Make sure that the image receptor and the central ray is perpendicular with each other. The tube angulates at 25 to 40 degrees horizontal or cephalad directed to a point between clavicle and chest wall. The amount of angulation should place the central ray nearly parallel with the rib cage. If a tangential projection of the clavicle should be obtained, but the patient can't assume lordotic or recumbent position, Tarrant method may be performed. So for this, the patient is in seated position, leaning slightly forward while grasping on the cassette. The resulting image will be magnified as a result of increased OID. To compensate with the magnification, an increased SID is recommended. The central ray is directed 25 to 35 degrees antero-inferiorly to the midshaft of the clavicle to project the clavicle above the thoracic cage.